Good morning. My name is Bill Stauffer. I'm the Executive Director of the Pennsylvania Recovery Organization Alliance. It's my pleasure to introduce you this morning Deb Beck. She brings over 30 years of clinical, policy, and legislative experience working in the alcohol and drug abuse prevention and addiction treatment field for her positions as a drug and alcohol consultant and president of the Drug and Alcohol Service Provider Organizations of Pennsylvania. She is also a member of the Therapeutic Communities of America, a national organization, and is co-founder and board member of the National Alliance for Model State Drug Laws and a board member of the Pennsylvania Recovery Organizations Alliance. Welcome, Deb.
Oh, thanks. That makes me feel old, Bill. Thanks so much for doing this. I think it's really important that people have this basic training on how to get help through insurance for addiction treatment. I think the first slide is now up where you can see it. It reads training objectives. Now here's what we hope to accomplish. Pennsylvania has a very strong law, that's Act 106 of '89, mandating addiction treatment in all group health policies purchased in the state. These are generally employer-based policies. And then on top of that comes the Mental Health Parity and Addiction Equity Act. This was Patrick Kennedy's bill that went through on the federal side, and the Affordable Care Act also on the federal side. And what we hope is to provide some basic information on how each of these laws relates to the other and how you can gain treatment through these laws for loved ones or yourself. Why does healthcare coverage for addiction treatment matter? Well, I think everybody listening to this already cares, or you wouldn't be signed up. But 1 in 4 families is struggling today with a loved one with an untreated addiction. And there's been a long history of healthcare insurance plans not covering addiction treatment. And this is crazy, of course, because this is one of the leading disease killers in America. And our people not only die from the illness, but it's much more expensive to die from the illness than to treat it in the first place. It's critically important that people in the community understand how to use addiction treatment coverage that is available in the laws. You're going to save somebody's life. The next one's kind of simple. It just talks about knowledge equals empowerment. This is so you can help others or yourself access addiction treatment that is already covered under an assortment of laws and come to know a little bit about how those interrelate. Here we go. This is PA's Act 106 of '89. This is an employer-based policy, and this would be a policy purchased in PA for employees, and typically this is a business that's not a self-insured plan. So the first thing you want to know is who is the employer. If it is a small business down the street with 5 to 10 or 50 employees, 60, 70, they probably purchased a plan in PA for their employees, and there are minimum benefits. These are the insurer has to provide these. They have no choice. They have to follow the law. And the benefits are laid out here for you. You'll see detoxification is separate from rehab, which is separate from outpatient, and then that's separate from family and intervention services, and there's an additional treatment section beyond that. Now, the reason why the 7 days detox per admission, but times 4, there were some compromises on the way to passage, but the idea is our folks sometimes circle around for a while before they land and go for a couple days in a detox, and we needed to make sure that people had access as they made up their minds about the severity of the illness. Technically, you could get 28 days in a year under the Act 106 policy. Now, the minimum of 30-day rehab, the contemplation here was that these are still employed people. If you look at the year of the bill, 1989, it took us, we got it introduced the first time in 1980. We were trying to stop the bleeding, where people who didn't get help when they were still working ended up falling into the public side or sometimes losing their lives. So we were contemplating people who were a little less damaged. The opiates in those days weren't as strong, but nonetheless, look at this, a minimum of 30-day rehab, minimum, non-hospital residential, and then you got 30 units of outpatient or partial on top of that. and the additional treatment section adds additional units. What we were thinking is sometimes people start to come to grips with childhood trauma at the very end of their 30 days of units of outpatient or residential, and they may need a few more units of service to finally learn how to handle that problem without picking up a drink or a drug. I just think that's imperative that people have a chance to work those issues through in a sober and clean environment. Now, the family counseling intervention services are dramatically underutilized in the state, and I would love to see people start insisting on access to this service. Your loved one with an addiction may be in another state, but the family may need to begin to get together and plan an intervention service. That's also funded under the law here, as well as family counseling. The family counseling is in licensed facilities by the Drug and Alcohol Department, meaning it's family counseling geared to drug and alcohol, not a generic kind of family counseling. Okay, what kind of plans require the Act 106 treatment? Well, 106 requires all commercial group health plans, and that includes HMOs and some self-insured plans. That's a bit of an outlier. The Children's Health Insurance Plan and the new federal health exchanges also fall under Pennsylvania's Act 106. Conversely, who doesn't fall under it would be the Veterans Administration or Medicare or Medicaid, government kind of plans, and mega self-insured plans that are in multi-states. This isn't too hard to tell. If you've got someone in front of you and they have an employer-based plan, if you Google the plan, you can quickly find out, or the company, find out if it's in multi-states or in multi-countries. If it's in multi-states or multi-countries, it probably does not fall under 106, and state law also does not apply to Medicare or the veterans benefit. Now, we had a heck of a fight. Pennsylvania's Act 106, again, we introduced the bill in 1980. It got through in 86 the first time. The insurers basically followed the law, and then about 92, in that window, profit-making HMOs came into the state and said, nope, we're going to manage this benefit. This is the key provision of the law, and the one you really want to manage, make sure you understand. Under the law, the only lawful prerequisite to getting help is a physician's or psychologist's certification and referral. Certification and referral, because we didn't want to have the doctor certify you and then you'd have to go to an HMO in Wisconsin to get referred somewhere that you may not want to go or may not even be in the state. So the law says the only lawful prerequisite is that. There is no pre-certification under Act 106. I'm going to say that again. There is no pre-certification. There's no medical necessity review under 106. If you permit it, you're permitting violation of statute. So how does it work? Well, you would call up and say, gee, is my loved one a paid-up subscriber? Is Deb's policy, is she a current subscriber? And the insurer says yes. You already know it's a 106 policy based on the prior information, and what you would need to do at that point is say, fine, where do I send the script from the physician or psychologist? There is no medical necessity review. Now, by the way, the insurers don't like this. They thoroughly dislike this law, and as we were getting the law enforced in Pennsylvania, they took us to court. And when I say took us, it meant the state of Pennsylvania. The Attorney General of the state of Pennsylvania stood up for this law and went before the state Supreme Court, and it was upheld for its unusual clarity. That's the highest court in Pennsylvania. There's no place else for the insurers to go. So if they are doing a medical necessity kind of review, they're violating this law, and this PA State Supreme Court has upheld these provisions. What were we thinking about? Well, if you have someone, I was working with an employer-based EAP, Employee Assistance Program, who was used to putting people directly in detox, and now he was being told he was going to have to refer them sometime in 2 weeks to a managed care firm down the street that was being paid a fiscal incentive to not provide care. And his employee drove trucks throughout a large city. He couldn't do that without endangering the employee or the city. This law contemplated immediate access to care for this illness of denial, where people stay out when in fact they should go into treatment, and where it saves money for the insurer anyway if they go in. So this is the most important provision. It doesn't exist in any other state. The only lawful prerequisite is certification and referral from a licensed physician or a licensed psychologist. Let me preempt one of the questions you're going to ask, which is, can it be the facility's physician? The answer is yes. If you can drag me into the facility, I'm in withdrawal, you know I need to be there, yes. It could be the person looking at the trembling body. The bill's prime sponsor and I in 1980 actually discussed this provision and decided that the person looking at the trembling body ought to be able to make the decision. And the Pennsylvania Supreme Court has upheld that provision. So that's your most important law, state law. But now how does the state law relate to new federal laws that have gone through? Well, Patrick Kennedy and his father got busy and got through the Mental Health Parity and Addiction Equity Act of 2008. Wow, there's a mouthful. We call it the Parity Act. It also applies to Pennsylvania's Act 106. It leaves Act 106 undisturbed and applies to it in ways that you'll see in a minute. And it also applies to the Affordable Care Act's health exchange plans, which we're going to talk about in a minute as well. Here we go. The Mental Health and Addiction Equity Act, MHPAEA, or the Parity Act. This law was enacted in 2008, and the regulations coming off the federal side took multiple years to get settled, and there's still some argument around some pieces of it. What it says basically is that anybody who's got a group health plan that has any coverage, now this is a national law, for treatment of addiction, has to provide it in parity with other medical surgical conditions. Now let me repeat that. Any group health plan with any coverage. So let's say there was, you had a plan in Wyoming and it provided only 2 days of outpatient services, or there is a state that provides $500 a year, but only for outpatient and pre-certification on top of that. There actually are state laws like that. What it would mean is that those provisions are out because they have to be provided in parity with med-surgical conditions. Now, it also says mental health. Now, why that matters is you could see a state that has no drug and alcohol coverage or a plan, but it has a little mental health coverage. Well, if it has either, it has to have both, and they have to be provided in parity with comparable medical surgical conditions. Great idea. Now we're having some difficulty with enforcement, but it's a great idea. Now this is a little more detail. What this means is that the financial restrictions can't be any more restrictive than those used with medical surgical conditions. So for example, there can't be separate cost sharing requirements for MH or drug and alcohol up and above the cost sharing for other physical health. And again, the financial requirements on deductibles and copays and all of that and out of pocket can't be any worse for drug and alcohol than they are for comparable med-surgical conditions. Now, one of the problems we're having is how do we know? How do we figure that out? Treatment limitations, same thing. They can't be any more restrictive for drug and alcohol or mental health than those used for med-surg. And that could be numbers of days of coverage, numbers of units of outpatient, more restrictive medical necessity procedures. So now keep in mind, MHPAEA parity applies on top of 106. 106 already defines that there are no medical necessity procedures, and MHPAEA doesn't change that. It's on top of that. It was very clear. We did a lot of work in D.C. to make sure of that nothing in the Parity Act disrupted the care provided under 106, and in fact this should be an assistance on top of 106. Now here we go. They have to publish. Now these are non-act, let's say it's a non-act 106 plan, it's a self-insured plan, a big mega company, some multi-state company buys a plan. They have to publish the medical necessity criteria, so you know why you're being denied care. If you ask for why you were denied, they have to tell you. Believe it or not, that's not been the law. And again, why our little state law is actually such a special law is that they can't deny care as long as a physician is certified to need. Now, if you're not a 106 plan, you're in some other kind of a plan, you're going to need these pieces. They have to share the medical necessity determination, and we're working with some now where it appears some of the insurers are like making them up, as well as the reasons for denial. They got to spell those out. Also, if out-of-network coverage is provided for med-surg benefits, then they have to provide out-of-network coverage also for drug and alcohol addiction. So I hope that helps a little. Now, the Affordable Care Act extends the reach of the Parity Act, and this just gets more and more complicated, as you will see. Here comes the Affordable Care Act. We're only talking about the pieces that relate to drug and alcohol here. This federal law was enacted in 2010. The idea was to make sure there was access to health insurance for all citizens of America. In relationship to drug and alcohol, there's a section of the Affordable Care Act that says all qualified health plans have to cover certain essential health care benefits. And there's 10 or 12 of those listed, like OBGYN care, but drug and alcohol and mental health are also listed. So any plans that fall under the Affordable Care Act and don't fall under Pennsylvania state law still would have to provide certain essential health care benefits, including drug and alcohol and mental health. And those benefits have to be in parity with other illnesses. I know this is really complicated. Now here we go, Affordable Health Care Act again. The Affordable Health Care Act and how it works will become increasingly clear to all of us over time. But look at some of these provisions that I just think are terrific. And when I hear about people contemplating the repeal, I'd hope at least they wouldn't touch these pieces. No lifetime dollar limits, no annual limits. We've seen a lot of benefit with the third bullet, the extension of benefit coverage for people up to age 26. We've seen a lot of young people come in for treatment under the Affordable Care Act's provisions. And you also cannot be denied coverage generically based on a pre-existing condition. That's a big step forward. Now, does Act 106 apply to the PA health exchange plans? Let me talk for a moment about health exchange plans. Health exchange plans are a requirement of the Affordable Care Act, not Pennsylvania. The Affordable Care Act required setting up health exchange plans for people who had no other coverage. It might be an entrepreneur who doesn't have employer-based coverage, or someone who's working in a business doesn't choose to be covered by the employer, or the employer offers no health plan. In Pennsylvania, moving now into drug and alcohol, the health exchange plans set up here in the state of PA are 106 plans, which means that they fall under the original rules that you saw earlier here. If a licensed physician or a licensed psychologist certifies to need, you get the care. There is no medical necessity review. Again, I think the feds were working very hard to not disrupt state laws where they are stronger, and we're very grateful for that. And now, again, a little more on the exchange plans. A lot of these will be individual policies. It used to be that individual policies could be almost anything. It means under the health exchanges, the individual policies are going to have to pick up addiction treatment as well. Now, what do you do if you can't access care? What you want to make sure is that your client has a certification and referral from a licensed physician or a licensed psychologist. And a sample we're going to give you in the next slide. I would do this no matter what kind of a plan you're under. Because though this works best with an Act 106 plan, doctors are often hesitant at managed care firms to turn down care from a licensed physician who's actually looked at the body. That makes them a little bit nervous. So I think it's a good practice to follow the Act 106 approach no matter what kind of a plan that you have.
And Deb, we're going to post this on our website so that people could get it.
Bill informs me that you're going to have on the ProA website a copy of the sample certification referral form. By the way, all the treatment facilities that we work with have a copy of that. So if you take your loved one to a licensed addiction treatment facility, they already have a copy of that, and they can get that filled out and they can send that in to start your care. Now, we also provided a couple of places where you could file a 106 appeal. You will see that PA Insurance Department, DASPOP, is also, we should be copied, get the releases of information signed, copy. The Parity Act is federal, so you're going to have to file that with the federal government, but I would recommend also cross-filing with the Insurance Department and also to DASPOP. My group's kind of like the watchdog. We're always there checking. I think it keeps everybody honest when they know that the public light is also on a case. I also sometimes just have suggestions that may speed your process up. Now, Bill, you wanted me to talk a little bit about the federal employee fight.
Yes.
We were really surprised to find that shortly after the Federal Parity Act went through, Federal Blue Cross dropped residential rehab as a covered benefit for federal employees. Now, there's over 100 different plans federal employees can choose between, but because the name Blue Cross is known to everyone, people generally sign up for that. So it's over 60% of the federal employees. Federal employees, there's about 4.4 million nationally. Pennsylvania has over 200,000. What happened is they were providing outpatient benefits if you needed them, hospitalization if you needed it, but if you needed the mainstream residential rehab, you couldn't get it. And there was a long battle. There was a combination of a political battle and also a legal battle that resulted in a recent ruling. Ruling is actually an appropriate term. It was actually in the new plans coming out in 2016 from Federal Blue Cross now include the full range of services, and they've resumed covering residential rehab and licensed facilities.
And there was a lot of advocacy behind that.
There was a lot of advocacy behind that. Bill's exactly right. What happened is a couple of treatment facilities ate the cost to let our lawyer try to figure out why this was so hard. The appeal process, you could be dead before you get through the appeal process. And the facilities took very good care of a bunch of patients while we went through an endless process that finally resulted in the outcome. Some of our political leaders here in the state of Pennsylvania were involved as well. It was a legal strategy combined with public policy advocacy, and I think it worked.
Thank you.
Oh, Bill also has provided some other resources you'll see in the back. Office of the White House. There's more information there on the ACA. By the way, if leaders, if you're having trouble understanding the Affordable Care Act, its relationship to the Parity Act, this is hard, and it is new, and some of the regulations are new, and this is going to take a little while till it gets settled in. You'll see Patrick Kennedy's website there. This was under his leadership that it went through. He also worked hard to protect Pennsylvania's State Act 106 from any negative impact of the Parity Act. So instead we have a real positive thing going on here. And we're doing a lot of work now to try to get the Patrick Kennedy MHPAEA law fully enforced in Pennsylvania. You'll also see DASPOP's website.
And I just want to thank everybody for taking the time to listen to this. Really valuable information. Deb, very grateful for you to take the time out today and put your expertise on this. This has been a tremendous fight to get Act 106 enforced. That's gone through most of my career, and I just want to say that it's a testament to people like Deb that thousands of lives have been saved through Act 106. And
well, if I can butt in here, for those who are in recovery or family members in recovery, we got the bill introduced in 1980, but the long reach of the fellowship community was all over the advocacy effort over all those years to get these laws in place. So this, you probably are going to have a lot more questions because we are still battling through to develop a clear pathway for enforcement on these more recent developments, the MHPAEA law and the Affordable Care Act. But what's neat is I think the future is very bright here. I just think just about everybody's going to have coverage in some form, or does. We have to figure out how to help you access it. With the advent of Governor Wolf, Medicaid expansion also has opened up coverage for another group of people, often described as those just above Medicaid and below private insurance. So we have to figure out how to use these new tools to save lives. Thank you, Bill, for doing this.
And thank you very much, Deb. Take care, everybody.